All right, medical minds, let's break down the diagnosis of stable angina in a way that actually sticks. First up, clinical assessment. The story always starts with the patient. I listen carefully to the chest pain. Is it a tightness, a heaviness, a pressure? Does it last just a few minutes and come on with exertion? That's typical angina. If it's sharp, fleeting, or sticks around at rest, I'm thinking atypical or even non-cardiac causes. I always ask about the entourage of symptoms: shortness of breath, palpitations, fatigue, or even syncope. Then I check the risk profile: age, male gender, family history, high blood pressure, diabetes, high cholesterol, smoking, obesity, and that all-too-common sedentary lifestyle. Past heart problems? That's a big clue. On exam, most stable angina patients look fine, but I keep my ears open for the S3 heart sound, listen for lung crackles, and check for pedal edema. These might hint at heart failure. Diminished pulses or brutes? Could be peripheral vascular disease tagging along. Next, baseline labs. I check cardiac biomarkers mainly to rule out something acute. They're usually normal in stable angina. But lipid profile? Absolutely. Fasting glucose or HbA1c for diabetes, renal function, and a full blood count to spot anemia, which can make angina worse. Time to hook up the ECG. Between episodes, it might be perfectly normal, but sometimes I catch old MI scars as Q waves, or signs of ongoing ischemia with ST depression or T-wave inversion. Left ventricular hypertrophy or conduction blocks can also show up. For functional assessment, stress testing is clutch. The treadmill test is classic. If the ST segments dip during exercise, that's a red flag. Stress echo lets me see if heart muscle movement goes wonky under stress. Nuclear scans like SPECT or PET help spot areas of poor blood flow versus dead tissue. And for patients who can't exercise, pharmacological stress tests step in. Imaging? Sure. Echocardiography checks the heart's pumping and wall motion. Coronary CT angiography gives me a non-invasive look at those coronary arteries and the calcium score. Cardiac MRI is my go-to for understanding tissue health and blood flow. But when I need the final answer, I go to the gold standard invasive coronary angiography. It shows me exactly where and how bad the blockages are, and helps decide if the patient needs a stent or bypass. So that's how I diagnose stable angina, step by step from history to high-tech imaging. Keep this approach in mind, and you're well on your way to mastering the basics of cardiac diagnosis.